an acute toxicity or subacute toxicity. The latency is less than 90 days from the end of radiation therapy, typically 3-9 weeks. Radiographic findings are much more common than symptoms because most of the patients do not actually develop a clinical syndrome, but the clinical severity has a very wide range, and the clinical course is typically acute. And there are most of the time some problems of interpretation even before the COVID-19 era, in terms of overlapping with the typical clinical and diagnosis patterns of bacterial pneumonia, viral pneumonia, and also immune-related toxicity. So radiation is another factor that may complicate our interpretation of clinical data and radiological findings. And it is something that we need to consider at a multidisciplinary level in trying to discuss together what are the findings. The classical classification that it is the one that most radiation oncology will know and use in a clinical practice, and is superimposable to the CTCAE common toxicity criteria. Define a grade 1 as mild symptoms, so simply dry cough, grade 2 persistent cough requiring antitussive agents. Grade 3, grade 1 and 2 are really something that most of the clinicians regard as a pure, is a common finding that most of the time don't need a true treatment. What we are interested in, obviously, is a grade 3 or grade 4 severe toxicity. Most of the time we have a grade 3 in less than 50% of the patient, but most of the time we are our attention is high for the patient developing a grade 3 toxicity, which means severe cough, non-responsive to narcotic agents, dyspnea, radiographic evidence of acute pneumonitis, and grade 4 and grade 5 are very rare events in conventional radiation therapy outside clinical trials. So the diagnosis is based on clinical symptoms, on radiological findings. For radiation pneumonitis, what is very easy to remember, but it's always important to underline, is that obviously radiation pneumonitis occur inside radiation volumes, and so you cannot make the diagnosis of radiation pneumonitis without having a cross-check between the radiation fields and the radiological findings. It's something that in my clinical practice I always important to recognize this finding, because most of the time is if a pneumologist or a medical oncologist or other clinicians that obviously do not have the idea of what has been treated in the radiation portals and simply look at what is described by the radiologist, may just confuse a radiation pneumonitis with a bacterial or a kind of another infection. So it is important to talk together about it. The typical pattern is, however, sometimes complicated when we have patients that are hypersensitive or have some other pulmonary comorbidities, for example, interstitial pneumonitis. Interstitial disease, so fibrotic interstitial disease, and this is important because there are some atypical presentation that we need to take into account, even if they are rare. And so it is not always true that just having a radiological finding of peritumoral pneumonitis means radiation pneumonitis. It depends, and some other cases are much more complicated. Typical radiological findings are truly superimposable to what has been described by my colleagues for both viral infection and as well as immune-related pneumonitis. This is one of the most interesting topics this evening, particularly because we are talking about that. It is impossible to discriminate on a pure radiological basis between a COVID-19 infection, immune-related pneumonitis, or an overlap of these different events in terms of radiological findings. It's actually very difficult. We may have localized pneumonitis, but we may also have bilateral involvement and fibrosis. So what are the other diseases? Can be radiation-induced lung injury, obviously infection, especially viral infection. That's why COVID-19 is a confounding factor. Also lymphangitis spread and cancer progression. The drug-induced lung injuries, immune-related or chemotherapy-related, pulmonary hemorrhage, and cardiogenic pulmonary edema. Obviously, factors suggesting recurrent or progressive disease are sometimes easy to recognize when you have a progression of symptoms, radiographic changes outside treatment volume, anemia, anophthisis, or other symptoms, but it's not always true. So again, it is quite difficult and multi-factors situation. So the lab tests are not typically helpful. So we have marker of indication that can mimic such, for example, PCR or LDH that can mimic having any kind of bacterial or viral infections. For patients with bilateral gangrenous opacity, we consider bronchoscopy, and especially in the times of COVID-19 pandemic, because obviously if the swab is negative, there is but the clinical and radiological findings suggest the possible infection COVID-19 together with within 90 days from the end of radiation therapy with clinical symptoms. We now need to perform bronchoscopy, as Dr. Stella also said, and the pulmonary function tests are typically restricted, but again, this is very similar to what we find in infection pneumonitis. So the general model of radiation injuries is basically defined as an inflammatory effect that mimic a viral pneumonia or a bacterial pneumonia, but it's much more localized. At the end, we have in very grade 4, grade 5 cases, obviously we have respiratory failure, which is a rare event in radiation therapy for lung cancer today. But this is what can be. This situation can be reversed by the use of corticosteroids most of the time. So likely what we do for immune-related events, and it is basically a matter of interstitial pneumonitis. Sustained by T1 cytokines, TNF, IL-1, IL-6. The fibrosis is sustained by TGF-beta, IL-4, IL-10, 13. What we are most interested in are the T1 cytokines because, again, as Dr. Stella and Dr. Curioni said, there is a role for this cytokine storm also in COVID-19 pneumonitis, and interaction with the inhibition of PD-1, PD-L1 axis may again interacts with radiation effects, which are pro-inflammatory at some dose, and if they are very localized, maybe also immunosuppressive or immune activating, depending on the volume of lung that is irradiated, the fractionation, and some other factors, such as, for example, the use of chemotherapy or immune-related or immunotherapy. So at the end, it's very difficult to say radiation is pro-inflammatory or immunosuppressive or immune stimulatory. It's a combined. The signal of radiation in terms of physiopathology is quite complex to interpret, and that's why we have this clinical presentation. Single variable models to predict the occurrence of radiation-induced lung injury have been tested in the past. We have many data on dosimetric factors. We also have data with the interaction of chemoimmunotherapy. We know that some drugs are some kind of chemotherapy drugs are a little bit at higher rate of toxicity if combined with radiation, such, for example, bleomycin or gemcitabine. But these data are not so well confirmed. So most of the time, any kind of chemo is very well tolerated. That's why we use concurrent chemotherapy. The immunotherapy effect is less studied. We don't know exactly what happened to the lung when treated larger field with a concomitant immunotherapeutic agents, but we have a lot of data with maintenance. With maintenance, nothing happens. It's very safe. With concomitant radiation at high dose, we don't know. There are many trials ongoing combining different anti-PD-1, anti-PD-L1 agents with radiation, and so we will see in the future. There are also some patient-related factors, such as the presence of interstitial lung disease. What is the risk associated to contemporary chemoradiation? It's very low, as you can see from two randomized, well-conducted, very high-quality trials with a quality check on radiation therapy. We have a grade 3 radiation pneumonitis less than 5%, and so this is very important. We also know that with IMRT, probably we will be able to reduce a little bit the rate of pneumonitis, even if this rate is not so high also with the 3D CRT. But it is important to notice that. And we don't have any kind of randomized comparison between IMRT and 3D CRT. These are the data plotted by kind of treatment in terms of radiation technique from the RTOG 0617 dose escalation trial, but these results are important. They have a clinical impact for our practice. And we also have data from the Pacific subgroup analysis analyzing the pneumonitis rate and occurrence and also the time of onset and duration between Durvalumab and placebo in the Pacific trial. As you can see here, we have the time of onset is typically 55 days in both arms. The median days is 73. From the first dose of Durvalumab is 55 days, from radiotherapy 73 days. The duration is around 2 months. And basically, there are no difference in time of onset and severity of pneumonitis between placebo and Durvalumab. So the discontinuation of, for example, of Durvalumab, which is interesting for radiation oncologists, obviously, because we are talking about stage 3 and we are treating patients with high dose radiation, is pneumonitis was the most frequent event leading to discontinuation. But as you can see, the percentage of patients who stopped treatment with Durvalumab was very low in this randomized trial, and the rate of radiation pneumonitis was around 1.3%. And so we have these data, these findings are in line what we know in our clinics, and are very, very nice. What is the problem is that we know that we need to talk with our colleagues from medical oncology, because they are giving immunotherapy, and if you have a patient with symptomatic or radiation-induced lung injury, which is clinically and radiologically confirmed, you need probably to stop treatments and doing corticosteroids, and then consider restart. You can also have some patient with asymptomatic radiation-induced lung injury. In this case, you just simply maybe need to stop until radiographic resolution. For symptomatic pneumonitis, which is defined as non-radiation induced, by this double check with medical oncologists and radiologists, and we know that we think about a possible immune-related, pure immune-related toxicity, obviously steroids, as Dr. Curioni pointed out. And for all other kind of organizing pneumonia, such as, for example, the suspect of COVID-19 or bilateral pneumonitis, or patients who are symptomatic, where you don't know exactly what is the main driver of the pneumonitis, radiation, immunotherapy, or even infections, you need obviously to consider antibiotics, prednisone, clinical slow tapering down, clinical resolution, but you also may want to consider stopping immunotherapy. So last 2 slides, I would like to report to you a case. I co-authored this case report together with my friends and colleagues in Brescia. They had a case of patients treated with chemoradiation and then maintenance Durvalumab with a diagnosis of COVID-19. The history of this patient is it's quite interesting. After the first 3 infusion of Durvalumab, the patient developed what they commonly define, and again, radiologists obviously was a clinical and radiological diagnosis, what they define as a immunorelated pneumonitis, even if atypical, but as we heard from Dr. Curioni, that it's not easy to know what is typical in an immunorelated pneumonitis. In any case, this was treated with corticosteroids. It was 1 month before the epidemic spread in Italy, so basically in January. And so the patient was stopped Durvalumab. Durvalumab was stopped. The patient was treated with corticosteroids, and then after 1 month, he had a good recovery. But the day when the patient did present in the medical oncology department for starting again Durvalumab, they report fever over the last 2-3 days. Now we were in the middle of the pandemic in Italy, so middle March, basically the end of March, and this was his finding, a radiological finding. He had a positive tampon because at that time, obviously, COVID-19 was one of the diagnoses that our colleagues took into consideration, and they did a swab. It was positive. Chest X-ray, as you can see here, the radiological pattern is slightly different from the one he had 1 month before, because we now see a bilateral interstitial typical COVID-19 pattern. And so this was considered as a pure COVID-19 pneumonitis, even if the patient did receive radiation therapy and Durvalumab and already developed a suspect immune-related pneumonitis. So it was treated with corticosteroids. Obviously, it did not continue Durvalumab, and at the end, unfortunately, the patient died because of severe respiratory failure in 3 days, and he was not intubated also because at that time, obviously, he had lung cancer. He was and this is something that we need to consider also. It's not related purely to we know that stage 3 patient may now be cured, but also we know that, and also would like to discuss with you on that, we also know that obviously our colleagues in the emergency department may see a lung cancer patient in a different way, as they see, for example, other patients. The priority for this patient was not very high for doing mechanic ventilation, etc. So probably we don't know exactly what could have happened if he was treated with a respiratory and artificial ventilation, but his clinical scenario was very bad, and at the end he died of COVID-19. So this is an example of the combination of 3 possible causes of pneumonitis. So last slide, we do not have clear data showing either an increased incidence or gravity of COVID-19 pneumonitis among patients receiving thoracic RT. We have some observational studies ongoing, but most of them, as Dr. Curioni presented, for example, the study by our French colleagues or the study by Marina Galassino, also the TerraVolt study involving many European and US centers, do not have a specific data collection for radiation therapy. So we will know many data on chemotherapy, on immunotherapy, but we don't know exactly what happened to patients that has been receiving radiation therapy at different doses. But we are working on that. Maybe we will have it a kind of dedicated radiation therapy data collection. We know that immune-related and COVID-19 pneumonitis show very similar patterns, and it's very difficult to get a differential diagnosis. So we know that previous radiation therapy and immunotherapy may alter the lung microenvironment interacting with COVID-19, but we do not have any kind of clinical data about that. The laboratory test, the bronchoscopy imaging clinical side should also be considered together the clinical presentation are very heterogeneous, and the overlap between different analyses is very common. So it is really difficult to work on this patient. Thank you.
Thank you very much, Andrea, for your presentation, and thank you, Maria Stella and Alessandra, for your great presentation. As I said you at the beginning, I have some comments, and Andrea, who knows me very well, knows that I'm quite provocative, and so please do not consider it something bad against you, but only to stimulate the discussion. All of you showed us that if we look at the etiopathogenesis of the COVID-19, we have a storm of cytokines. We do not discuss very so much about the problem of coagulation that seems to be one of the latest stages of this of the we can say the damage related to the COVID. At the same time, Andrea showed us that there are some pro-thrombotic events in radiation-induced damage that seems to be quite overlapping with the etiopanogenesis of the COVID, of the damage related to the COVID. At the same time, Alessandra showed us that a lot of the mechanism of COVID can be, we can say, changed or in any case influenced by some systemic drugs. Okay, so all of you agree on the idea that something can change in principle, looking at the etiopathogenesis. Okay, but at the same time, when we look at the clinical data, it seems to us that there is not a worse prognosis or a worse toxicity, even with the limitations of the number of patients that we have today. It seems to us that from a clinical point of view, COVID positive patients seems not to have higher toxicity related to the treatments. I'm wrong or correct?
Can I answer maybe, Berardino?
Yes.
I don't know if you hear me.
Yes, I can hear you.
So I think what you're saying is very important, but it's a postulation, because if we look at the Chinese data, it looks that it's worse. If you look at the French data, it looks that it's the same, what you're saying. So we don't know this yet. The data also from the Teravolt presented by Maria Grassino, these do not seem to have an impact. But what we have to take into consideration is a couple of important things, is that the cancer patients are very different one to each other. And the treatments we're giving are very different one from each other. And we know that when the patients are coming into a hospital as well, they were in the latest phase, they were much more protected than before. So probably also all the incidence of many other infections will be much lower in these patients, because we're much more careful with protecting devices. So I'm not completely convinced that immune checkpoint inhibitors might influence badly the outcome of COVID-19. We might postulate that chemotherapy might do this and therefore have a bad impact, a negative impact to the outcome. But this information, we don't have it yet. So we don't have it at all.
Yes. At the same time, the data by the Chinese population, obtained by the Chinese population, was about the mortality, if I'm not wrong, not about the toxicity of the treatments.
It was also severe events of occurrence of severe events.
Okay. In this sense, considering that immunotherapy, for example, works by increasing the response, the immune response And considering that the COVID increases the immune response, that's the provocative part of the question. Don't you think that it can be used as not used, but again, it could be an adjuvant in some situation, and this can explain why finally some patients that could be more damaged are quite helped by the co-infection. I don't know. It's a question.
Yeah, this I mentioned also the pro and contra, right, of immune checkpoint inhibitors in the presentation. So the contra to have too much of an inflammation, and the pro to have some inflammation in sense of an immune response against the virus. So I think it depends on the timing. So the issue of the timing is something that we know from CMV infections, for example. So I think if the infection would be taken at the beginning, and there maybe having a patient with under treatment with anti-PD-1 blockade might support the initial immune response. But having a prolonged immune response in the patient who is already on an inflammation phase, then it would hamper or it would induce more severe events. I think it's a matter of timing.
We don't
hear you.
Mute.
Sorry. And looking at the data from radiotherapy, if the problem is the timing for Alessandra, is a problem of dose in radiation therapy, because there are some very old studies using very, very low doses of radiotherapy that seems to have an immunosuppressive impact. And some studies are suggesting that very low doses of radiotherapy can reduce it can have an immunosuppressive role, and so be beneficial against COVID. Do you think that also considering the low doses of IMRT, etc., some data can be reviewed?
I think that the problem here is that we do need clinical data. We don't have any kind of observational data about the interaction of field size and dose of radiation therapy and the COVID-19 infection rate or the mortality rate in these patients. It is a problem because I think that probably I would expect with larger fields and larger doses, higher immunosuppression, like what we see with chemotherapy. At the same time, I think that if we're talking about smaller fields, such as, for example, stereotactic radiation or smaller field radiation, even if conventional fractionated, together with immune checkpoint inhibitor, we may also see a protective effect. In fact, we really do not know. I think the situation is a little bit confused now. I think that the ESMO recommendation are right, and also what with the colleagues in Zurich and in many countries recommend is right, to try to use an algorithm to select patients between those who should be treated because they have a curable cancer, they need the treatment, etc. And we don't have any data for avoiding radiation therapy in these patients. I will be a little bit careful and more cautious in irradiating with very large fields and with an aggressive chemotherapeutic regimens, patients with pulmonary comorbidities or who are, because I know that probably the immunosuppression that I can provoke with the chemoradiation, extended field, etc., would be favoring the possible COVID-19 infection. But this is again something that I cannot demonstrate in any scientific way. It's simply a consideration. So
a quite thank you, Andrea. A quite quick question. Are you changing, and I'm asking to Maria Stella, to Andrea, and to Alessandra, are you changing your practice in treating lung cancer patient? I mean, if you have, in the ideal situation, okay, ideal, we can say ideal situation, you have a patient that must be treated following the indication of the ESMO, okay? There is no discussion about that. You must treat him or her. You discover that this patient is COVID positive, okay? You cannot delay the treatment. You have not this choice. So the question is, would you deliver the standard treatment, for example, in radiotherapy, 60, 66 gray with concomitant radiotherapy, the same doses of chemotherapy, the same doses of immunotherapy, or would you adapt your treatment because or only because he is COVID positive? What is your practice?
So, in my opinion, talking from the respiratory system disease, I think that we have, of course, to change our paradigm and to take in mind that is the COVID-19 infection. I mean that we have to analyze, first of all, imaging of the patient, because if after the cancer, we could see some aspect and some imaging features that could recall a pulmonary damage from COVID, we have to take in mind this point. Unfortunately, we aren't able now to perform spirometry because of the problem related to the viral infection. So we don't have this tool. We only have imaging, and we have to reason and to see the image and the evolution of the, hopefully the CT scan, but we are now working back to the chest X-ray. Okay. Also with this patient. So I think that timing and the evolution of the CT or chest X-ray imaging should take in mind before decide and start therapy, of course.
Okay. Andrea? Will you change doses of radiotherapy or to decide not to deliver concomitant chemotherapy in a patient that who would be a candidate for concomitant radiochemo, for example?
But you know, we distinguish, I mean, in the clinical practice between simply positive asymptomatic patients and clinically symptomatic patients. So if we only have a positive tampon done as per screening procedures, for example, which is correct in this phase, in the present phase, I would simply delay a little bit our treatment, and I would not change the approach. For a clinical symptomatic patient, it's very hard to answer, and I don't know, probably it would be too dangerous to start a treatment, but at the same time you need to
it's a case by case evaluation.
I leave these questions to Dr. Curioni.
Of course, this is the kindness of the radio oncologist to the oncologist. No, I think we didn't have such a case. So I have to tell you the truth, we never had such a case in our department. But what we would recommend probably is if we could avoid the chemo, for example, then we would try to avoid it. We could also try to take the time by using, if possible and if indicated, an immunotherapy if we're thinking about a stage 3B. But of course, if we're thinking about an early stage lung cancer, of course, we would recommend resection and if possible, and probably we would delay adjuvant chemo. So, or probably not give at all adjuvant chemo. So this is a specific case, right? So when can I say I avoid the treatment? So we know that the benefit in early stages non-small cell lung cancer from adjuvant chemotherapy is this small. It's about 4% on overall survival improvement. So in these situations, I would probably avoid adjuvant chemotherapy or say we delayed it.
So
If we have to think about...
So we are saying
Sorry.
that we must be careful and cautious.
Exactly.
Okay.
Very cautious. I mean, it is stage by stage because you need to think about the setting, so the disease stage, but also what it would be the impact of giving such treatment. So it is completely different if you're thinking about a patient with a central localized tumor who needs urgent treatment, for example, a chemoradiotherapy in an inoperable 3A, and compared to a patient who would undergo adjuvant chemo. So the setting and the possibility to respond to treatment, so with it also the prognosis to the disease, from the disease, these are for sure important. And I would like to stress this point. Everybody is saying we need to talk about this with patients. I often hear it, but we really need to do that. And it's not always the same if we are talking about the disease and the treatment with a patient who is perfectly very well educated in biology compared to a patient who is maybe never had the chance to learn or to know about it. But patients know what they want from life, most of them, so I think it's really something to really take into consideration.
Thank you very much. Very clear considerations. There are no questions from the participants. So I'd like to thank you, all of you, very much for these presentations and for this interesting session. And I'd like to only make an advertising for the next session is about that will be about renal tumors on childhood, and it will be held on 11 June of at the same time. So thanks again, and take care.
Bye.
Bye.
Bye-bye.
Thank you, Dino. Bye.
Thank you, Dr. Filippi, Dr. Stella, Dr. Carioni, and thank you, Dr. Dabari. Ladies and gentlemen, the session has now concluded. The next TSO session will take place on the 11th of June, at the same time, and Dr. Norbert Graf, of the UKS-Universitätsklinikum des Saarlandes, Hamburg, Germany, will discuss with Dr. Waltraud Friesenbichler, of the St. Anna's Kinderspital, Vienna, Austria, the following topic: renal tumors of childhood. Thank you for participating, and have a pleasant evening, day, or night. Goodbye.